Bill, I'm so excited that we're doing this. I feel like I've been looking forward to this for weeks, but potentially years, because we've known each other for a long time, and we've never had a chance to sort of do something like this and have it recorded, and me having asking you questions, which I'm really excited about.
I know it's about time, Adam. It's been a long time. And I'm glad to see over the coming weeks and months, you're going to be doing this with a number of my fellow psychologists too. So you're going to be sick to death of us. So good luck.
Well, before we jump in, I just want folks to know what a legend you are, if that's okay. Bill is a licensed clinical psychologist. He's a certified diabetes educator, and he's the founder and president of Behavioral Diabetes Institute, which has a ton of awesome resources. And Bill is also the ADA's 2020 Outstanding Educator in Diabetes, which is incredible. And that will be a talk that I know will be important to tune into, because Bill's, we were talking about it about a week ago, and it sounds like it's going to be an amazing talk. And BDI is the world's first and only organization wholly dedicated to studying and addressing the unmet psychological needs of people with diabetes. And Bill has worked on diabetes distress and hypoglycemia fear, and has just done so much to move this field forward. So thank you for being here, Bill.
Thank you. I like the idea of being a legend. I think this means I've been doing this for a really long time. But
I mean that in only the most positive sense. But I was reading one way that I think your work has been summarized as this focus on evidence-based hope. And I thought we might start there, because being hopeful during this time is kind of helpful medicine, I think. And I was wondering, for healthcare providers who are attending, how can they promote hope and optimism with diabetes? Like, what are your sort of tips or resources or things that you recommend?
well, I'm glad you asked. For years now, I've done a lot of work with one of my colleagues back at the Jocelyn, Rich Jackson, where we've been compiling the actually enormous amount of studies that talk about the good news about type 1 diabetes. And we know for so many folks like you living every day with diabetes, you get inundated with the bad news, probably since the day you were diagnosed, about, look, this is all the terrible things that could happen to you if you don't take care of yourself, blah, 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 blah. And to this very day, the biggest annoyances that we see is people are still hearing the message that diabetes is the leading cause of blindness, end-stage renal disease, amputations, etc. People are with the idea that somehow we can scare people into taking better care of themselves for the long term. And not only do we know that's not true, that doesn't work, but that bad news is incorrect, and that there is so much power in sharing all the incredibly good news with folks that doesn't get heard. And so I know one of the things you're alluding to is one of my favorite examples that I love to show, where I say, well, had type 1 diabetes for, say, 30 years. And you look at a big population of people with type 1 have had it for 30 years, and they've had decent medical care. What percent of those people have run into the scariest complications? I have a little graph I show, and I put up the first graph, and I say, here's a fairly famous diabetes center, and they show that after 30 years, huge numbers of their type 1 patients already have gone blind, had amputations, et cetera, et cetera, et cetera. You can see the actual numbers. It's like 30% had severe vision loss, et cetera. And so I show that, and people go, yeah, it's kind of what I thought. But then I remind them, if they look carefully at the slide, that was actually from a study by Deckert and colleagues from 1978, that the kind of data you think is real is really old. And so then we show comparable data from the EDIC trial, long-term DCCT results, although the last good data we could see was maybe 10 years ago. But there, and you can show the exact differences. So instead of saying 30% of people have severe vision loss, it's actually 1% in EDIC. And last time I've heard any results, actually no one had gone blind. So, and you compare that with, we can look at fatal attacks, we can look at amputations, kidney disease, all of it. There is an enormous amount of ways of using graphical display to let people know the truth. Not that you're going to be fine, that you should ignore your diabetes, but the shift we have to make is to let people know that with good care, odds are good, you're going to live a long and healthy life with diabetes. And we think that's so important. At the BDI, we put it on mugs and t-shirts and everything we can think of, because it's very important. And sharing what we call evidence-based hope with folks, as you know so well, as you've done, is how we engage people to say, oh, that's why I'm doing all this. This is worth it. That you can excite folks with hope, not just by trying to scare the ever-living crap out of folks.
Yeah.
And I think we're seeing that to some degree now. I've been thinking about this, and Adam, I'm curious if you think this is true, that we've seen, even with COVID-19, how in a much more visible way, you can scare people into making behavior changes. But what we're seeing around this country right now is that that doesn't last forever, that it's getting old and it's starting to wear off. And just scary messages aren't that effective. There's actually a huge body of evidence about how effective they are. They aren't that effective, especially in the long term, and that's why it's insufficient. So anyway, sorry, I could get into lecture mode. I don't mean to do that.
Lecture mode is great when you're doing it, Bill. I love all that. And I think one of the things it reminds me of is this delicate balance we have in diabetes, which is, I mean, this is like kind of a serious medical condition. Like, you have to take care of yourself and you have to take your medicine, and you can end up in the hospital if you mess something up. And also you can live a long and healthy life if you take care of yourself. And I think like that is a tricky message to perhaps bundle in a 15-minute visit, 4 times a year or something like that.
Yeah. I don't think it has, because even in it, it's pretty brief. The reason, Joe, I'm sitting with you here in my office is that we know, with your engagement and hopefully me being a competent healthcare provider, hanging out together, you're going to do well and live a long, healthy life with this disease. Is that something you're interested in doing? I mean, that should be the intro to every conversation you have with your patients, right?
Right.
I mean, let's make sure we're on the same page here with this. No one's going to say no to that. No one's going to say, no, this long and healthy life thing, not really for me. No one's unmotivated to live a long and healthy life. So we start in the same place. It gets easier for everybody.
Yeah. I also, what you also reminded me of is that data you mentioned, which I love, that 2-slide combo that you show. And in the past 10 years, like, even diabetes has been transformed with CGM and automated insulin delivery and data. And I just feel like diabetes 10 years ago versus now is completely different for type 1, at least for type 1 diabetes.
Yeah. And it's funny, and I say that even when I show these slides. By the way, I'm happy to share those slides with you, and you could pass them off to anybody who's listening who might want them as well.
That would be awesome.
We have a lot more than just those two, actually, a lot more. But those are the two that seem to be most impactful. I forgot what I was saying. Oh my God. About
past 10 years.
Yeah. So, we don't really, when I show that good news based on the edict data, we have to remember, and I think you've highlighted this, that data is really old. I mean, we're talking about people were diagnosed now 40 years ago. And what they've been through and weren't able to go through, right? I mean, in terms of no CGM, limited score, everything, and in terms of what we know now. So what's it look like now? I imagine it's a heck of a lot better, and we just don't even know.
Yeah. Does scaring people have any place in diabetes?
Yeah, actually, I hate to say yes, but number one, we've been interviewing people over the decades and asked them, how did you shift from someone who was kind of ignoring diabetes and now someone who's kind of engaged with it? What happened? And for a subset of people, we see that people do scare themselves into starting to take better care of themselves. It doesn't mean we're any good at scaring anybody else, but we see that people can scare themselves into that. And there actually is a huge body of literature that these sort of scary messages that we've used in, public announcements for, drug abuse and everything has a small effect, but it's only small. And it's only when you combine it with what we call an efficacy message, meaning here's a scary message about bad things that can happen to you, but the efficacy message is, and here's what you can do about it. So that it doesn't have to happen. So when you combine them, it's okay. So there's a place for scary messages, but we should be humbled by the fact that it's never can be the whole game for anybody.
Yeah. And it should never be the leading message, which I think it very often is.
No, we've seen a generation of folks with diabetes who have been hurt by that.
Yeah.
Who've been told over and over again, these are all the terrible things that are going to happen to you. And what they do is they drop out of care, they drop out of seeing their health care provider, they've given up. I mean, that's one of the reasons we worked and developed this for so many years, is we've seen so many people who become so profoundly hopeless in the face of living with diabetes, they've given up. People need hope if they're going to be able to be successful. That's why we're all talking about vaccines these days, right? I mean, if you don't have some hope, everything starts to crumble.
Yeah. One of the things I think is tricky about glucose monitoring data is it kind of also has this balance of like, where do you as a healthcare provider focus? You know, so if you see a chart of CGM data, like what do you kind of laser in on? And I also have a 2-slide combo that I show. You know, it's this graph of CGM over 24 hours, and it's the glucose is in range. There's a huge spike in the middle of the day, and then it's in range the whole rest of the day. And I say, if you want to improve, where do you focus? And everyone goes right to the spike. You know, like it's like, gotta get that spike down. And I think one of the things both you and I care about is like, what's also working? Like, what is working and how can we do more of that stuff? Yeah. And I feel like that's a really tricky, non-intuitive thing when a healthcare provider who's been trained maybe in problem solving sees data. I'm curious, like, what you've kind of seen on that front.
Yeah, that's a really good point. And of course, I agree with you. We've been doing research about this for years, even back when we were only focusing on just, blood glucose monitoring with, strips. It is essential that if you're reviewing data with anybody, well, I shouldn't say essential, it's smart if you start with the congratulations. If you start with, let's look at what's going right for you. Just as a human-to-human contact, and if you want to keep someone's attention and you want to help them to stay enthusiastic, you start with what's going right. And the words of congratulations are huge. We informally did a survey of actually primary care physicians working in diabetes years ago, and we asked them about that. And 100% of them said, oh yeah, I always do that, which it's just not true. It's just not true. So just like your example, when you look at data like that, you start with saying, this is awesome that you've been successful so much of the time. And I think the other thing you said also is really important, which is that you can see why this is hard for busy healthcare providers. I got a waiting room full of people. I got limited time. I want to be useful. I'm trained as a problem solver. So my eyes, absolutely the first thing they do is they go to what's wrong and what can we do about it? And we're overtrained to do that. So it's very hard to be able to step back and say, okay, I'm just going to take a breath. I'm going to take 10 seconds and I'm going to sincerely note what's going well and acknowledge it. And for some of the patients we see, that's really challenging because they may be doing very little and be very disengaged. And so the point we always start with congratulations is, this is great that you showed up.
Totally.
So start with congratulations. And as you know so well, it will really go far. And you're more likely to, for the person who you're talking to, who's going to pay attention to anything you say after that.
Yeah. Thank you for showing up. Like just coming to the office is huge, like, and takes courage and takes time and takes money.
Yeah. You've done no monitoring. Your A1C is 11%, but you showed up.
You showed up.
Yeah.
Totally.
Yeah.
Yeah. Chris is letting me know that we have some audience questions, so maybe we'll pause here and hear what those are.
Yeah, so we got a couple of quick comments. One from Jillian saying that she also really appreciates the start with congratulations sentiment. I know that is definitely consistent with, at least with my sort of personal appointments with Dr. Saleh, like unofficial appointments. Like he always focuses on on the status of my green bar in terms of my time in range, and then we will work towards opportunities for improvement. But that is definitely a common sentiment of sort of agreement there. Another comment from Liz Warren saying that in the UK, well over 700 people each year get their 50-year diabetes medals, and this was just a few years ago. So she's obviously anticipating that this number will be higher now. Moving forward. And this, of course, only represents the people that actually apply for it. So in terms of thinking about opportunities for those conversations around, living with diabetes, thriving with diabetes, living longer into your life with diabetes, that number is going to continue to increase as tools and technology and things like that continue to progress and offer that opportunity for folks to leverage that sort of stuff to hopefully live a longer and healthier life. Do have two quick questions in, one from Joan. Thank you, Joan. Do you think we emphasize BG testing for people with type 2 diabetes?
Do we overemphasize it? I'm not trying
to. Yeah, that's all I've got. But I guess in terms of the different opportunities to address control and sort of understanding, because I hear from the outside, you hear, diet and exercise is always the thing to focus on with type 2, which isn't necessarily always the case, but they're always going to be, I feel like there are different opportunities for addressing type 2 diabetes, whereas with type 1, it's, you have this insulin shot or, it's bad news bears. In terms of blood glucose testing and how that can impact a potential treatment regimen for somebody with type 2 diabetes, do you think that specific component of it, I guess, do you think it receives enough emphasis, not enough emphasis? Where do you think it sort of falls in terms of where the conversation is today?
I think it's a really interesting point, because on the one hand, what we hear from our patients all the time, what concerns them, is when they feel like their healthcare provider is simply treating them like a number or a series of numbers, and they forget the human being. And again, the concern is that that's when people with diabetes drop out of care, right? And that's a concern when you overemphasize the numbers and you're being treated as a number. But is there a role for glucose testing, looking at patterns? Yes. I think the other critical part, and I assume this is related to this issue, is that we are big proponents of what we call the bang for your buck approach. So when we're sitting with individuals with type 1 or type 2 diabetes, and we'll ask them, we'll say, well, what does taking good care of your diabetes mean to you anyway? What do you know? And able to tell you perhaps 30, 40, 50, 60 different things they've been told they're supposed to do, right? I'm supposed to eat this, I'm supposed to not eat that, I'm supposed to be checking my blood sugars, doing this and that and everything. But there's this long, long list. And in diabetes education, it is rarely put forward to patients that all of those different self-care behaviors that are being recommended are, for you, not equally valuable. They're not equally important in terms of their likely impact on your ability to maintain good diabetes care. And that for every individual, I think we need to help them create their own bang for your buck list. What are the easiest things? What are the top 5 things you can do that are going to be easiest for you and going to help you be most successful? And I love going through that list with folks. Usually the one I used to start with, I go, here's the most important thing you could do. Number 1, don't smoke. And for the vast majority of our patients, they go, well, that's stupid. I don't smoke. And so I stop and say, congratulations. Let's go on to number 2. And for many folks, especially when we talk about type 2, for me, way up near the top of the list, because it's easiest, is, are you on the right medication and are you taking it? And if you're not, if you're missing shots, if you're type 1 and you're missing a lot of mealtime insulin, that's the biggie. I'm not too worried about if you're doing glucose testing, you're checking X number of times a day. I'm worried there's enough medication getting in your body. Not because the other things aren't important, but because the other things aren't going to probably work as well if that isn't done. But anyway, you don't have to agree with me. I'm just saying making that bang for your buck list with every individual you see is really valuable. And again, it helps people to stay enthused and not overwhelmed. So Chris, I apologize if I got way far away from that question, but it inspired me.
I mean, the good news is that these types of conversations are sort of prone and encouraged to go on these tangents and sort of long-winded answers, because it's not a simple yes or no topic that we're trying to address here, right? Like the human brain, the human emotional sort of system is a really complex thing. And to think that there was a black and white, yes, here's a 5-word answer to any of this stuff, I feel like that would be doing a disservice to everybody, including the years of work that you've put into all of this.
I have a tangent on that question if we have time.
We might have time, but we also have a series of questions that have actually come in now. I'm going to ask a couple of them, and then I'm going to let you, Adam, get back to. So I guess write down your tangent, and we can get back to that in a moment if you're okay.
I will have other tangents coming up, I can tell.
I am sure. So I have a follow-up comment from Joan saying that the current school of thought supports less daily testing, but more targeted testing. Thoughts on that, Dr. Polonsky, in terms of, obviously, you can only act whenever you have information, but in terms of trying to motivate somebody that might be sort of less inclined to test more regularly, focusing on like, all right, let's always check at breakfast as opposed to testing 4 times a day. Any thoughts on an approach like that?
Yeah, no, I mean, and again, we've done a lot of the research in the area. I mean, especially when you're talking about type 2 diabetes, it's been an enormous waste of time asking people to be checking their glucose levels, especially when most people have no idea what those numbers need to do about it, and no one bothers to talk to them about it. And so there's been this almost superstitious use of glucose monitoring over the course of years, especially in type 2, which has just been incredibly annoying and has led to some odd conclusions about how maybe it isn't worthwhile to testing. What we've been pushing, and what's clearly true, is as was referred to as smart testing, what we call paired testing, really makes a difference. When you're asking people to check in such a way so that it's actually answering relevant questions for them, like, is this medication working? Did I bolus for breakfast well? Why am I so tired in the evening? Then, in fact, I'm calling now, and I think I'm supposed to stop using those words. Checking becomes way more valuable. So yes, smart testing, yes. Chris, I could have said it easily. Yes, I agree. But I did.
All good. It's
all
right.
I just want to tag onto this because it relates to my tangent. I feel like this like continues to be a debate, and I think it's almost silly that we keep having it, because I think of blood glucose data as a self-learning tool.
Yeah.
And it's a tool for me as a person with diabetes to see where I'm at and recognize patterns and make changes. And so, of course, like if I only do that once a day at the same time, like what patterns could I possibly recognize? And if I do a study where I compare people who don't check to people who check once a day, like how much am I really gonna figure out? And because diabetes is so self-managed, it's critical to have self-learning tools so you can figure out what's working and not working for you. So I'd much rather have someone with type 2 wear CGM 4 times a year than check once a day for a year. It just feels like to Bill's point, like getting that structure and getting all the trends before and after is much more valuable. So I feel like it's more about like what is the right dosing of glucose testing or glucose checking, rather than should people with type 2 do it at all.
And I think that's what we're going to see in the future is episodic glucose monitoring for most folks with type 2. And that's the way it's going to work, and it's going to be very valuable. Absolutely.
It's funny to me too that, like, let's say in heart disease, would anyone ever debate the value of blood pressure monitoring? Like, no one would say, like, should people monitor their blood pressure to like know where they're at? But in diabetes, like, this is still such a debate whether people should have to check their glucose. And I feel like it's this weird thing, like as if people should not have access to data about their own bodies and their own conditions so they can be empowered, I guess.
I encourage the listeners to, excuse me, we did do a debate commentary in the journal Diabetes Care about 3 or 4 years ago. So I encourage people to go back and look at that, because it was a really fun debate between my colleague Larry Fisher and I versus some people who said, no, glucose monitoring is pretty useless, and a subset of people with type 2. And it was quite fun.
So to that, the tests or checks, whatever phrase you want to use for it, that's information. There are 2 questions and comments that have come in, one from Francois, one from Aaron. Thank you both. Talking about information overload and diabetes burnout. There's some very thoughtful things that have been sent in, but essentially, like, how do you deal with that side of things in terms of managing the importance of the information that's coming in with the fact that depending on the resources you have available to you, that information is going to be coming in nonstop every 5 minutes, and that can be a lot in terms of the mental load that comes with diabetes. And on that note, I'm actually going to hide and moderate some of these questions and come back in a few minutes, and we're going to answer the rest of them because they keep coming. People are really excited to talk about this stuff. Go for it.
I think this is if I answer the question, Chris, I actually just did an online program a few days ago where this came up. And a young lady with type 1 said, I've been using CGM and I don't know how I want to keep using it because I'm just so overwhelmed by all these numbers. And we do hear that a fair amount. And we had a lovely chat about it. And I said, let me ask you a question. I had this funny feeling you're not overwhelmed by the numbers. You're overwhelmed by the expectations about your numbers. That you're completely freaked out every time you see a number that feels too high to you, or when you're seeing the trend arrow moving in the wrong direction. And she went, yeah, that is it. And I said, well, what should be? How do we mark success for you? How do you know when you're being successful? If you ever have a high number, does that mean you're failing? Anyway, and I told her this is a very important conversation you need to have with your healthcare provider to really know what your expectations to be and what's reasonable. Because you do have a lot of data, and glucose values are going to be jumping around because that's what they're going to do, right? And it doesn't have to do with you being good or bad. That's what's going to happen because we are not imitating a pancreas perfectly yet. So I just think that's an important issue. I think it's by talking with people about ours, healthcare providers, expectations about what you should expect to see, how we're going to mark congratulations to success, and talk about that in a collaborative way. I think that can make a huge, huge difference. Adam, what do you think of that, by the way?
Yeah, I think of CGM data as like a speedometer for diabetes. So it's just a way of sort of seeing how fast or slow I'm going, and then I take action based on it. But I try to emphasize when I talk about this that like there's no value judgments to the numbers. So the numbers aren't good or bad. They're data that we use to make decisions, to learn, to and I think that pulls away a lot of what you were alluding to, because a lot of the burnout, I suspect, comes from the story around the numbers, and the story is changeable. The other thing I think that can help is remembering how complicated what we're trying to do is. So this is when I often throw up the 42 factors that affect blood sugar, because I think that reminds people of what we're actually trying to tackle here and how much of diabetes is out of our control. Yeah. And that can take a little bit off, like, oh yeah, the numbers are gonna bounce around because like, look how insanely difficult this is, that like what we're trying to tackle, and like, look at the tools that we have to do it. Yeah.
Adam, you remind me, years ago, you would probably remember this, back when we only had glucose meters, at the BDI, we used to hand out little teeny tiny adhesive strips that would fit under the glass of every single glucose meter. And on the strip, it just said, remember, it's just a number, right? Because we see how much people equate these glucose numbers with their self-esteem or self-value. And no, it's just a number. And we found that to be, and we still find that to be super useful.
Yeah, and I love that message because it's not that you're saying the data doesn't matter. It's that the data does matter, and it's not a judgment on how well or poorly you're doing. It's just information to help you figure out what's happening and make changes.
Exactly. Yeah.
Christopher, do we? Yeah, I see your.
I mean, I got more if you want me to drive some stuff. Here we go.
I have a couple more prepared, but.
All right. So from Emma, let's see, dear Bill, brilliant discussions as ever. Thank you, Emma. On behalf of Bill, thank you. How do you find virtual consultations have impacted your work and your communication and your efforts with your patients, especially for people with diabetes that might be struggling with high distress or anxiety? Global pandemics are weird, which is an understatement, but as telemedicine becomes the way moving forward, how are you sort of managing that whenever, especially as you're talking about something as intimate as mental well-being, being there face to face is going to have a certain impact versus a computer screen that's sort of blocking the opportunity for empathy and connection?
Well, let me say two things about that. First of all, I was talking to a physician colleague of mine a couple of days ago, actually. And he was seeing all of his, he sees a lot of people with type 1 diabetes, and he only everything is virtual, obviously, now. And he told me about how much better all of his interactions with his patients are, and how much more relaxed and at ease all of his patients seem to be, and how much more productive all of his conversations are. And we were chatting about it, and I asked him, I really want you to write, because I think it's so important. And I had this funny feeling that part of the reason it's been so much easier is because for so many of his patients, they're not going to the principal's office to talk about their diabetes anymore. They're just hanging out at home talking about it. And it's shifting the relationship in a good way, which I think is wonderful. I will say for me, in terms of my own interactions with my patients online, and who have always been freaked out and distressed, because that's who I see. It is worse now, though. I'm miserable having virtual interactions, but it's what we have to do. And I think I'm miserable about it because it is much more draining and more difficult and harder for me, because I'm looking for nonverbal cues that it's much harder to. Sometimes I'll say something and it's having I'm producing a reaction, and it's hard for me to tell. So it's easier for people to be hidden. So I find it more challenging. It's what we have. We're doing it. I think we're doing it okay, myself included. But I do find it more difficult. And like everybody else, I'm missing that human contact. Not, with my patients, with people I love, with everybody. So I guess I would just say, everybody else, you have to be paying even more attention than you usually do to really look for things that could easily go right by. So that's all.
Yeah. All right, next one. Thank you for that. We got a question in from Jane saying that congratulations on good results is great, but the good results alone are also a starting point for investigating what patients did to get those results. So it's not just great that things went well, but also what did you do to make those results go so well? Not just paying lip service to good results, but to use them and learn from them.
Absolutely. I couldn't agree more. And I'm sorry we were too abbreviated not to actually include that. Couldn't agree more. Yes, yes, yes.
I like that. There we go. Another comment in from Liz. Thank you, Liz. I find it really hard to accept praise for my personal diabetes management, though it's often given. Though it's often given, I don't believe it. And even when I am, whenever I am told that stuff and when I do believe it, I also feel like I'm just being humored. I guess her question is ultimately, any tips for a perfectionist who never thinks that they're doing well enough when it comes to these types of conversations?
It's been funny. You made me think of a couple of things. I do a lot of training in motivational interviewing, and part of motivational interviewing, one of the parts of it is providing what are called affirmations, and which often can be points of congratulations. And I spend a lot of time trying to train people about the importance of being sincere about that. That kind of, if you're congratulating people in an insincere way, without it really being heartfelt, it's actually worse than not doing it at all. So I can understand that might be going on, but I also understand what she's saying, that if she is a perfectionist, and again, perfectionists always end up feeling defeated by the definition of what being a perfectionist means, that it's hard to hear points of congratulations when you would never, ever congratulate yourself. And I guess I just want to empathize with that. I mean, we know that actually living, especially with type 1 diabetes, pulls for perfectionism. Too many people have grown up with type 1, very sadly, not of their own doing, but because of how this disease has been treated, healthcare provider, thinking that there's only two ways I can be with my diabetes. Either I'm perfect or I'm bad. And it gets into our conversation that Adam, you and I are having about the numbers. That's crazy and not fair. There ain't no perfect and there ain't no bad. We have to, that's why it's important to have these sort of agreements about what does success look like? How do you know you did great? How do you feel like you made it today? And are those expectations you're having reasonable? And again, oftentimes people have unreasonable expectations, and that's why job. I get to meet a lot of those folks.
Yeah, and the thing I'll add is, in cognitive behavioral therapy, there's this thing of black and white thinking or all or nothing thinking. And I think as a person with diabetes, it's
Yeah.
very easy to do that in so many parts of diabetes. So like the examples you just provided, Bill, one that I often do is, well, I don't have an hour, so I can't exercise.
Right.
And for me, the antidote is always like, what's in between I can exercise and I don't have an hour? How about 5 minutes? How about 10 minutes?
Sure.
And so I think like seeing that gray area between whatever two opposites there are can be helpful.
And as you know, my colleague, Susan Guzman, always likes to talk about helping people achieve what she calls a healthy good enough. And what does a healthy good enough look like? And it's that way of finding that in between the black and white in a way that's reasonable, folks. Really important. Glad you said that.
So sort of along those lines, a comment from Barbara. Thank you, Barbara, talking about how part of her diabetes management, including having access to a community center where she could lift weights, swim laps in a pool. Any tips for people with diabetes that are struggling now that access to those resources in terms of their diabetes management, that exercise, those external facilities are likely not going to be accessible to them for any sort of foreseeable future?
Yeah. I hope Adam will have a good idea. Mostly I just want to empathize because I feel the exact same way. People often say, well, why do you have to exercise at a gym? And I go, well, it's so much fun for me to exercise at home. I really only like to exercise if I'm around people who look as miserable as I feel when I'm doing it. But we've all adjusted and doing what we can. But that's a very practical question. And so I'd happily talk to her more about where she lives and how she does that. It's, we're creatures of habit, and she's used to doing things at a certain place in the geographical realm. And the idea of shifting to new habits is hard for all of us. And if she lives in a place or an area that's not safe and you got to wear a mask, and it's a turnoff. And it takes oftentimes just a lot of individual problem solving to figure things out. Adam happens to be the star at doing that, by the way.
You don't have to answer that, Adam. It's okay.
Yeah,
I feel like that's sort of like entrapment.
No. Bill's right. I think it is really hard. I think there are some pretty good apps. Like I use one called 7 Minute Workout that requires no equipment, and it takes 7 minutes.
That's a killer.
What's that?
It's a killer.
It's hard. But then you're done in 7 minutes. I also think reframing, I think there can be this tendency to feel like during this time, I have to find a way to kind of be as good or as productive as I am normally. And so I think with exercise, just getting any exercise in during this time is amazing. Like because everything is a logistical hassle now. Like getting groceries is a hassle. Walking the dog is, so not putting as much pressure on myself to sort of be my normal self often allows me to like, all right, like a 20-minute walk today, like might be my exercise today. And that's okay because this is a weird time.
I guess, again, as you're saying, you're walking away from the black and white thinking about exercise as well. Yeah, good point.
So to that end, Jillian recommends Grey's Anatomy on Netflix. There are 16 seasons, and if you have a treadmill in front of a TV screen or an iPhone or whatever, that's a great option for you there. Thank you, Jillian. What else we have here? We have a couple of good comments that came in. I'll make sure I find the right one. Yes. So this one is from Liberty. Thank you, Liberty. How do you give hope to the people with diabetes that already have complications? It's hard to find the joy in life when you are in a lot of pain from neuropathy, have gone blind, loss of limbs, suffer from kidney disease. If those things are already a part of your life, how do you, where do you find the hope there whenever they're already experiencing, some of the diabetes boogeymen that are often told about a diagnosis?
Yeah, and it definitely gets harder then. First of all, just putting on my professor hat, there is data that, again, with good care and effort, even though you've already been hit hard by complications, you can still reduce your risk for those things worsening or other things happening over the course of time. The core feature of what depression is when you start feeling powerless. You feel like bad things have happened to you. You feel like there's nothing you can do about it. And helping people to have some sense of renewed control over their lives. What can you do? To what degree can that make a difference? Can it help you be functional and successful and help you to have joy in your life at this moment? That's what's really critical. We work a lot with people who have had tons of terrible complications, and it's heartbreaking, and yet we've found ways to help folks to hang in there and stick with it because they know they want their lives to still be productive. They still want to have joy in their lives. And they know that with, hanging in there with their diabetes care, that's achievable. Again, I just think about empathy. It really sucks, but we hang in there with folks and we know they can do well, usually.
Two comments that are sort of similar, talking about sort of broader access and opportunities sort of there when it comes to interpreting diabetes data, but also having access to these tools. One is from Anonymous saying, it's clear that diabetes tech, CGMs in particular, can help people to get better outcomes, but what do you say to people who can't afford or access those tools and technology? And sort of along the same lines, this is a question from Desi. Thank you, Desi. How hard is pattern management for people with diabetes who have lower health literacy or don't know how to read a graph? Even if they have access to the tools, but they don't know how to actually make sense of them. Where do you start there?
Yeah, let me work backwards with that, if you don't mind. I mean, we're not completely backwards. The second question. I have a very weird feeling about health literacy. I think we've kind of overemphasized it. We talk a lot as healthcare professionals about we have subsets of people in our population have low levels of health literacy or health numeracy. And, that's kind of a code. We used to refer to those people as stupid, which was wrong to do then, and it's wrong to do now. So while it may be technically true that people will score on the low levels of a health literacy or health numeracy test, if people are struggling, it's simply because we haven't given them the support that they need. I was part of several big trials that have looked at the impact of introducing CGM, for example, for people with type 1 and type 2 diabetes. And we included measures of health literacy and health numeracy. And we didn't find that mattered very much. That, if you give someone a pump or you give someone a CGM and you don't give them any support at all, it's only to be a limited number of people who probably will figure it out. For lots of folks, and certainly including a lot of people who haven't signed up for especially CGM yet, they're going to need help. They're going to need someone to hold their hand and think through some of this stuff and figure it out because they're not used to that sort of logical thinking or the use of graphical information. But again, we can use words like health literacy and health numeracy, but it doesn't mean they're stupid or bad. It just means they're not informed in that way. And they're going to really benefit from the support that we can offer. That's what's really key. About affordability, I don't know what to say. It's annoying and it sucks that not everyone in America with diabetes, especially with type 1, doesn't have access to a CGM right now. I hope Adam has some words of wisdom. Mostly it just makes me discouraged and upset. I hope it gets better as we patiently wait for more competition and Dexcom G7 and everything else. Adam, what do you think?
I agree. I couldn't have said it better.
I was hoping you'd give us more hope.
Well, I will say in the fingerstick realm, I think there are some good programs for a certain amount per month. You can get unlimited strips. My Sugar has one. One Drop has one. I think those are more affordable for people who check frequently. I also think, going back to what we talked about earlier, like just having, say, a Freestyle Libre like a few times a year could be amazing for someone with type 2 diabetes who and Freestyle Libre Pro or the G6 Pro, the professional CGMs, those are often really well reimbursed, I think, including by Medicare. And so a healthcare provider could provide that and at least get a little bit more data for folks to work with.
By the way, there was an old study, as you may remember, showing that episodic CGM in a type 2 population actually had great success, worked really well. I don't think it's ever been replicated, but it's pretty good.
All right. I'm going to batch a couple of questions here around the broader logistics around telemedicine, and especially with the sort of nature of your work, Dr. Polonsky. One is from Jillian. What are the barriers that you've encountered in terms of legal or compliance in terms of using Zoom for your video consultations, especially when it comes to identifying, I guess not certainly on the legal side of things, but in terms of utilizing Zoom, recognizing those nonverbal sort of cues for you. And then separately, one from Bhakti and one from my groceries just came in. That is not a question, but another question in from
We're so
Diane.
happy that you got your groceries.
I'm multitasking with the best of them, because that's what diabetes is like. You have to juggle all these things, including your groceries coming in, your dog about to yell at the person delivering your groceries, that person. And also the question from Diane asking about the timing of all these things. Like there's still a broader issue for some, at least in terms of the questions that are being asked, of how do you manage the time constraints that come with appointments from time to time. I know that I speak to some educators who say like they'll spend as long as they need with their patients. For others, they still have to try and stick to that typical 15-minute sort of timeline when it comes to their patient interactions, and that become more complex as you're dealing with Zoom and other technical details like that.
I think I'm so excited about your groceries, Chris, that I kind of lost the entire question.
I'm going to unmute my microphone for 1 second so you can hear the dog, and then I'll mute my microphone and let you guys handle these questions real quick.
Mostly I think you're going to be speaking in a few weeks with Mark Heyman, and he's going to be able to answer those questions a lot better because he's doing these things a lot more and is a lot more informed than I am about the nitty gritty and the legal side. I probably should be paying better attention to the legal side. Certainly the work we do, we know that we wouldn't be using Zoom. There's other platforms that allow us that are more HIPAA compliant, that are still free for folks, that can be used. The biggest constraint, and again, I'm not sure how interesting this is for the audience, we're constrained because of state law, right? So unfortunately, and this has been very unfortunate, I really am fairly limited. I can't have online therapy visits, consultations, counseling visits with anyone out of the state of California. I guess I shouldn't be admitting this, but I certainly have done this. Have done counseling sessions with people outside of the United States, because, well, try and get me. But with other states, it continues to be an issue. And there's a lot of work on that to try and fix that, but I think that's still in progress. But again, Mark Heyman is the person to talk to a lot of these things. He's really in the weeds and in depth on this, and I look forward to what he'll tell you about that. So I can't say more.
My sense is some of the laws have been relaxed on some of those fronts recently, but I'm also not as up to date on that.
And I've heard that as well for certain professions. It's still so varying from state to state, that I don't pursue any of that too much, because it's just such a mess and you're just looking for trouble.
Yeah.
It's really unfortunate.
Yeah. Bill, maybe one of the prepared ones. So for healthcare providers who are doing visits and they want to connect on a mental and emotional and really psychologically sound level, do you have any other tips for starting out visits? We talked a little bit about maybe for ending visits, things healthcare providers can say that would be encouraging and hopeful and help build the relationship. Because in mental health, we talk a lot about the relationship and how important that is for helping with change. And I think it doesn't maybe get as much attention in the medical field, but what can folks think about or do, or resources that you recommend?
Oh my God, that's such a big question. You remind me, there was a fairly new study that came out of Sweden, I think. Can't remember exactly. I think it was Sweden. And they were looking at, oh no, maybe it was the UK. It was the UK. And they were looking at sort of indices of physician or healthcare provider empathy. And they identified a large group of people with type 2 diabetes shortly, about a year after they had been diagnosed. And they were asking these patients to basically rate their experiences with their healthcare provider. Do you feel like your healthcare provider was listening to you, engaged with you, looking at you, on your side, felt like he or she knew what they were doing, etc. What was really important about this study is they then followed those people for more than a decade. And what they looked at 10 years later was whether any of those people with type 2 were still alive. And they found that the scores on that empathy rating questionnaire 10 years earlier was a pretty strong predictor of mortality. And you didn't even, I should say, the healthcare provider didn't have to score really high. You just had to score in the top two tertile. So it wasn't being very empathetic. It was just being not horrible that really seemed to be important. But that to see a strong relationship like that with mortality was incredible.
Wow.
So much of this, and again, I highlight that just to say empathy, empathy, empathy. What does that mean? How do you do that virtually? The most important thing is here we have this remarkable new platform where we still know the most important aspect of empathy is, am I being a good listener? And it is harder to be a good listener because, just like Chris showed us, my dog's barking, there's groceries coming, I've got other screens here with all sorts of other interesting things going on. There's other stuff happening. It makes it that much harder for me to say, I'm looking at you, I'm paying attention to what you have to say, I'm concentrating as best as I can. And I'm giving you feedback that I've heard what you said as well. It's just something as simple as that. Am I really listening well? Am I looking at you? Am I not being too distracted?
Yep.
And am I responding in some way to let you know that I'm actually hearing what you have to say? Not just what I have to say, but what you have to say. Little things like that magnify tremendously in terms of promoting our relationship as well as my patients' engagement in their own healthcare condition.
Yeah. Bill, you remind me of in motivational interviewing, I think it's the 3rd edition of the Rolnick and Miller book. It's just called Motivational Interviewing, Helping People Change, or Conversations About Change. And that book is awesome because you probably have it. It's awesome because there's transcripts of therapy sessions and you can kind of see how, open-ended questions and affirmations and reflections and all of the things that help with, I think there's a lot of tactical advice in that book about empathy.
Better one, but yes. Yeah, no, absolutely. I think my favorite is this old one from Rolnick. It's called Health Behavior Change.
Ooh.
It's unfortunately the most boring title of a book I think I've ever seen. Like, who would want to read a book about behavior change? But Rolnick is one of the guys who started motivational interviewing. And just like you said, what I love about this book, rather than the huge motivational interviewing text, is that it's much easier and it's full of so many examples. It's one of the few books I've ever read where I was jealous that I hadn't written it. I went, God, I wish I'd written this. I would have had a much snappier title, not helping. But
Bill, the other thing you reminded me of, because I just took a class on common therapeutic factors in mental health. So what are the ingredients that help people regardless of, what helps people do well in therapy?
Yeah.
And it's been shocking to me because I would have thought, as a therapist, the technique is what matters. Are you a CBT person and how good are you at CBT? And the research is so clear. The relationship is the most important thing in terms of people. There's other important things like what the client brings, but the relationship between the therapist and the client is the most important ingredient, more so than technique. And I was just blown away by that.
Yeah. And there has been a lot of work on promoting training, actually, healthcare providers how to be more empathetic. And again, there's very, very simple things. In fact, I'm glad you mentioned that because I think we can apply this to virtual. One of my favorite studies, I think it was out of University of Pennsylvania, simply took medical students, and before they walked in the office, walked into the exam room to see a patient, they would take 1 minute, and look at the person's chart, just briefly, just the first page, and try to put themselves in that person's shoes, just for a minute. Just to go, I wonder what this is like for that person. And not do anything else differently. Just do that. And that had a huge impact on patient satisfaction scores and all sorts of other things. Just that. So I think we need to apply that virtually a little bit, you know. In other words, I'm about to do a call just to remind myself, who is it I'm about to speak with and what might this be like for them? Or how can I ask the question to find out more about that?
Yeah. One of the things I was thinking last night as I was reading something was it was about community mental health, and this it was about systems of care. And so this case was about a family who had to go to 3 different meetings all across town in a day, and the times were set such that it would have been impossible to meet all the demands of all 3 systems. And what I thought was lovely was just asking folks, like, what's a typical day like, as a way of saying, like, oh, wow, you have to be at 3 different places all across town. It would be impossible to meet that demand, as a way of being like, wow, I totally understand why this is really difficult.
Yeah. Oh, that reminds me. I wish we had so much more time. Adam reminded me of I'm getting into too many tangents. I think Chris is going to kill us, but I'll stop.
I'm looking at my pile of groceries outside that I need to bring in, and also at the clock that says we're at the top of the hour. So here's the thing. There are 27 open questions right now. We can't go for another hour. I would love to. We can't. I think there's an opportunity here for us to at least copy down these questions and answer as many of them as we can in a follow-up blog post that we have published on Tidepool blog. Adam, I'm pretty sure you can handle a lot of these. And then Dr. Bill, if you're available for some of those, we can collaborate on something like that and get that out to everybody to address as much as we can. I do want to ask a follow-up question, or a final question, to sort of round this out before we close it out. And this does sort of conveniently segue into a future webinar with Dr. Jill, but there are a bunch of questions that came in regarding burnout with teens, with children, caregiver burnout of people caring for teens, in terms of like the family dynamics and dealing with the different ages and things like that. Again, I think Dr. Jill will be able to, is going to be spending the entire hour talking directly about this, but from your perspective, Bill, is there anything from a high level that you would recommend people focus on when it comes to either living as a teen with diabetes, caring for a teen with diabetes, and managing the complexities of raising a teen that also has to live with diabetes? Like there are layers upon layers of challenge there.
Yeah, that's just like an hour-long answer I can give you. Well, all I can say, I'm going to start by saying, I'm really glad you're going to talk to Jill about that. You know, we learned so much about how tough this is for parents, how challenging this is for teenagers. We know a lot about what we advise parents to stop doing to make themselves miserable and make their teens miserable. We've certainly done a lot of research in this area to understand that. We understand that you can't scare your teenager into taking better care of themselves. This is where those fear messages really don't work, because your teenagers are invulnerable and will live forever. So probably our oldest and best research from one of my colleagues really suggests that we know that families are more successful when they can sit down at let me say this very clearly, a dispassionate moment, and arrange some agreement about who exactly is responsible for exactly what aspects of Joey's diabetes care. So maybe I as a parent saying, Joey, you're in charge of doing all your shots and XYZ, and I'm going to be in charge and make sure there's, a decent dinner that shows up every night at a certain time. I'm not in charge of whether that dinner actually makes it into your mouth, but I know I'm in charge of making sure it's there. And I would also like to be able to, check your CGM once a week, or be able to follow you on an episodic basis. But we have to have some agreement about who's in charge of what. And when that occurs, the evidence is very clear. That's when teenagers do better, and that's when everybody feels better. And it's having that discussion at a dispassionate moment, quiet time, that can make the biggest difference. Jill will tell you more about that next time you talk to her, but again, I want to empathize with parents in particular, because this is really tough, because I know parents feel guilty and overwhelmed, and they feel like anything they do is wrong, right? So if I if I don't stay on top of my kid every moment, I'm being a bad parent. But if I'm staying on top of my kid and being a nag and a policeman, I'm being a bad parent. So it's really tough for them in any case. So make Jill figure it all out. That's what I'm telling you.
Challenge accepted. Thank you, Dr. Polonsky, for spending an hour of your day with us, sharing some of your insights and wisdoms there. Obviously, this could go on forever, and it should, because this is really important. To that end, I'm going to hit this little button over here and remind everybody that tidepool.org/telemedicine is a place to go for all of our telemedicine-focused resources. As a reminder, we will be following up to this webinar with a blog post to try and address as many of the 26 open questions that we have left, because you all are really engaged with this. Next week, I will be hosting a series of shorter webinars talking about the basics of interacting with the Tidepool platform, from creating your accounts, sharing your data, uploading your data, and viewing your data. As mentioned, Dr. Jill Weisberg-Benchel will be back with Adam Brown, who will be back on June 2nd to talk about mental health tips for parents and teens as it relates to all of this madness that we're currently living in. And in the following week, Dr. Mark Heyman will be joining Adam to talk about mental health and telemedicine, more on the logistics side of things as well there. Tidepool.org/webinars is the place to go for all of that in terms of registrations. I'll be sending out email reminders to everybody to encourage you to engage with all of that fun stuff. And finally, support@tidepool.org. When in doubt, send an email there to get started with asking any questions you have, and we will address them as quickly as possible. Adam, thank you. Dr. Bill Polonsky, thank you. This has been a lot of fun. There have been a lot of follow-up comments at the very end saying thank you, thank you, thank you. So one more time, thank you.
Thank you. My pleasure.
Thank you, Bill. You're the best.
I really enjoyed it.
Have a great
and
day.
Adam, I want to hear more from Adam next time, but write me back.
Take care.